Now the final example of services for doctors in this section of the workshop is from Ireland, where in the year 2000, in March 2000, the college set up a service for doctors called the Health in Practice programme. What was interesting about this particular initiative was that the initiative came from the members of the college. It came from the GPs up, and I'll tell you about the needs assessment findings prior to that setting up in a moment. This is, for those of you who are not familiar with where Ireland is, this is our little island on the very west of Europe. And the reason I have these here is because I have a passion for the GAA, which is our Gaelic Athletic Games. And it's very much about teamwork. And this photograph here includes, I'm somewhere in the back there, but very proud that my daughter has an All-Ireland medal for the National Championship in ladies football. And there's a reason for me putting this here, in that the Health in Practice programme is very much about teamwork. And we might develop that theme later on when we come to our small group work. So we have a system of confidential healthcare, education and support for GPs set up by the ICGP members who are GPs. And what's interesting about this is that this model is based on primary care. Many of the Doctors' Health initiatives globally are based on psychiatry services and addiction services. It's almost as if they are the only issues we need assistance with when we're managing our own health or the health of colleagues. However, our message is very different. It's based on primary care and it's GP services in particular. This is our logo, which encourages doctors to take a look at themselves and to self-assess and self-reflect at periods of time throughout their careers, which can span many decades. We aim to promote good physical health, which includes acute illness and chronic illness and chronic disease management, as well as psychological health, occupational health and well-being. These are the three main sections of the service. We have medical education, which includes teaching trainees from the moment they enter specialist training programs in general practice, and also includes continuing professional development and continuing medical education. We have the health service, which I'll tell you about next slide, and we have a telephone helpline which is available to GPs during working hours, Monday to Friday, where they can, sometimes when they call, they simply need reassurance that yes, they do need to access or find a GP for themselves. Sometimes they need signposting for themselves, and we also receive direct calls from spouses of GPs and partners, the wives, the husbands. We've had calls from parents of young doctors. We've had calls from adult children of GPs. We've had calls from primary care management. For example, a GP who's not making their financial claims has come into this, several have come into the system because the health service claims system has identified that there may be a health problem, and calls from community pharmacists for perhaps irregular prescribing patterns. So there's many different pathways into the service. Our networks are based on the GPs for GPs model, and we also have a small number of psychiatrists, a network of counsellors and psychotherapists, psychologists, and a small group of occupational physicians. Everyone is an independent practitioner, health professional. They are not employees of the college. And all of these health professionals, we have over 150 health professionals in total in a network across the country. They participate in a formal selection process, formal and informal peer support. So this was what Irish GPs said about wanting a specific service. This was the needs assessment that was done. They wanted confidentiality. They also wanted privacy. They didn't want to be sitting in the waiting room with their own patients or nearby practice patients. They wanted some privacy. They wanted choice. They wanted somebody to coordinate their care and assist them with follow-up so they do not have to chase their own test results, which doctors are all love chasing test results and x-ray results and intercepting their own investigations and try to get there before they're treating doctors. And most importantly, they felt that those who would be treating doctors felt they needed assistance with the role of being a doctor's doctor in training and in support. And many of the GPs who responded said they also needed assistance with the role of being a patient. Following our, in addition to our own needs assessment, we looked at the international literature, and we could talk for days about this whole issue, but it's quite obvious from the international literature that quality improvement in doctors' healthcare is needed and is necessary. We specifically focus on doctor-to-doctor interaction, on the consultation within our service, and we focus on this consultation and try to improve the quality of the consultation, and on medical education, as I mentioned earlier. So the vision is that every doctor should have a GP, and any doctor may consult any GP. So in a sense, we're broader than the GP network, because many doctors who consult our panel of doctors are not GPs. They're from all different specialties as well. What have we found? Well, the big three categories for GPs and other doctors accessing our network GPs, more than 50% of the issues, and there are multiple issues, but more than 50% are for mental health, cardiovascular and sick leave advice reasons. 30 to 50% for gastroenterology, gynae and obstetrics reasons. 10 to 30% for dermatology, neurology and the various other issues, and less than 10% for musculoskeletal. So that's what our network of GPs are seeing. For the network counsellors, the biggies, over 80% for personal relationship support and assistance with managing personal relationships. Anxiety and stress, both work-related and personal, around the same level. Work relationships, 40%, depression, 30 to 40%, and these are some of the other main issues that crop up from time to time also. Parenting issues, childhood abuse and trauma complaints and litigation. So just to finish, just as our patients' ill health may affect their performance, we see that in our everyday clinical work. Their ability to work safely and to earn a living, their mood, their self-esteem, their family, and have impact on their relationships and leisure activities. We're no different. Illness in any of us can have the same impact that illness has on our patients, and I think it's very important that we don't forget that. And just finally, our knowledge and training do not make us immune to illness or distress, and that's why we're going to lead into the next section of this workshop, which is group work. And what Margaret and I would like you to do now is to break into groups of about 6 or 7, if you wouldn't mind. And what we will do is we have 2 tasks. They're related tasks, and when you get into your groups, if someone could volunteer or if someone could nominate a reporter just to give the key points to the microphone at the end when we call for a group discussion at the very end. And don't be afraid, don't be intimidated by having to speak into the microphone. There are no right or wrong answers to the question we're going to ask. This is about sharing views and conferring with others in your group. And if the reporters could give us 3 or 4 points, that would be wonderful, but you can discuss as many points as you like during your group work. So if you'd like to break into your groups, we'll give you the task then. Thank you very much. And the group work will last for 15 minutes.